Okay, good afternoon, everybody. I'm here to introduce Dr. Adrienne Green, who is currently the President and Chief Executive Officer at the San Francisco Center for Jewish Living, which is California's largest not-for-profit part-skilled nursing facility and associated assisted living and memory care center. Previously, she was the Chief Medical Officer at UCSF Health for many years, and she also had a long career as a hospitalist with a passion for caring for older adults. She has been an inspiring mentor of mine since I've been on faculty here at UCSF, and she has been integral in the expansion of geriatrics clinical programs and the implementation of the age-friendly health system at UCSF Health. And what I've learned the most from her about is the subject of her presentation today. So I'm excited to present Dr. Adrienne Green, who will be sharing her physician leader's journey, aligning your clinical niche with the needs of the C-suite.
Thanks, Stephanie. It's such a privilege to be able to do this. And I also feel like a little bit of an imposter because you are the experts in the field of geriatrics. So what I've tried to do is string together a couple of different things that you may have touched on, but that maybe I can add a different perspective to. So objectives to understand the skill sets needed for success as a physician leader in the C-suite, understanding how to leverage career and professional development opportunities, and then just understanding the challenges and opportunities impacting post-acute and skilled care in 2024. So I thought what I would do is share my career journey, which goes from here over to San Francisco campus for Jewish Living, and hopefully we will get there in probably a little over 21 minutes. For those who haven't spent time at San Francisco campus for Jewish Living, I thought I would tell you a little bit about it because one of my missions is to spread the word so that when you are sending patients there or you're helping your patients to decide if they are interested in senior living, you have a little bit better picture of what it's like to be there. Or if you're teaching your fellows or residents or students, because they have patients going there. And then I thought I would share a little bit about the post-acute market trends. So sort of three somewhat different things, but they all kind of weave together. So my career journey here started at Mount Zion, and I was a resident at Stanford. My chief year, I essentially was a hospitalist. I spent 5 months as a medicine attending and decided that I wanted to be a hospitalist. There wasn't much of a hospital medicine program at Stanford at the time. And I came up and I was one of the first cohort of hospitalists at Mount Zion. So completely, separate discussion would be what was it like to be like part of the, sort of early days of the hospital medicine movement. When I was at Stanford, UCSF and Stanford merged. And then in 2001, UCSF and Stanford had a divorce. And as part of that, Mount Zion closed. And I then integrated with the group over here. And we'll tell you a little bit about what happened after that. So sort of breaking this down a little bit, what I feel was very, very important in the very early days was that I did a ton of clinical work. And that clinical work included not just hospital medicine, but medicine consults. There was a skilled nursing facility at Mount Zion. There was an acute rehab unit at Mount Zion. And so I got sort of my first exposure to taking care of patients in a skilled nursing facility at that time. And then when Mount Zion closed, UCSF had this arrangement with the skilled nursing facility on Pine Street, which was then called or owned by Vencor. It is now CityView, like several companies later. And we had an arrangement there, actually not dissimilar to what UCSF is doing with San Francisco campus for Jewish Living now. So I got a taste of what it was like for patients to be in a skilled nursing facility, the importance of the transition, what kinds of things we should maybe be telling our patients when they transition to a skilled nursing facility and the expectations that we might want to set. Then we dissolved that relationship, or UCSF dissolved that relationship with Vencor, but I sort of held on to what I learned from that over the years. And from that experience, really came this affinity for caring for older adults. And I've sort of always said that if I were going to do my training all over again, I would have done a geriatrics fellowship. The palliative care service here also needed help at the time. And this was at a time when people weren't boarded in palliative medicine. And so I spent some time on the palliative care service because I also like taking care of patients at the end of life. And you'll see that, those are some of the things that really drew me towards my current role, and sort of linking the clinical work with the kind of environment that I want to be a physician leader in. But I really do think that, and I was sharing this with the fellows earlier, doing a lot of clinical work earlier in your career is just so important in terms of building clinical skills for starters, but then really building relationships and credibility that will carry you very far, whether you want to be or end up in an administrative role like mine, or in an educational or research type of leadership role. So if we fast forward a little bit, one of the things that happened after the UCSF and Stanford divorce is there were like tons of consultants roaming around this place. And one of the things that these consultants who were really helping to put the leadership team back in place and sort of, develop a new org structure, one of the things that they recognized was that the transfer center and the case management group needed a medical director to partner with each of these areas. And so I took on that role. And one of the things that I learned a ton. One of the things that I discovered was that I really like bringing multidisciplinary teams together to solve problems in the hospital and build new systems. And I think that I've built on that over time. Being in the transfer center and working with case managers on discharge planning puts you right in the middle of hospital throughput. And I will say that's one of the things that has sort of been a constant throughout my career, has been working on things related to throughput. It also put me on a lot of different committees that were very visible from a hospital administration perspective. And I think if you're invited to be on a committee and you sort of contribute in a meaningful way, not sort of, sitting there like on your phone or on your computer, but really being engaged, I think people will sort of notice you and think of you when new leadership roles come up. And then I think that it also gets you involved in different kinds of projects where you can build different kind of skills and get different perspectives and experiences. During this time, I did some quality improvement training, which I think is really important. And then in 2005, I started the California Healthcare Foundation Leadership Fellowship, which is a 2-year fellowship. I was in like maybe the 3rd or so cohort. They're now well into, cohort 20 or something along those lines. It's a very, very well-respected 2-year program for folks who have some leadership experience and want to really dig in deep in areas like there's a business section, there's a section on communication, there's a section where you dig into your MBTI and personality type and how that works with other people's. There's an improvement, quality improvement or performance improvement section. So really allows lots of opportunity both in seminar style, homework, small groups, and project-based learning. So I got a call at some point from the chief medical officer. This was like back in 2006, who basically said to me, it's been really great working with you on all these projects, and it's really valuable. And I don't see you writing papers and doing research and publishing anything. Please come work with me in the chief medical, office. And he was a proceduralist and really wanted someone who was an internist who really understood the hospital to help out. And so I was like, yes, this sounds perfect. And joined really sort of in this leadership role that was very much across all hospital services at that point in time. And a couple of things happened. One was in 2007, we had a huge regulatory crisis at UCSF related to a medication error. And we had regulators here like all the time. It was very intense, but I learned a ton at that time, sort of being like the central physician, working with all of the different groups to help fix and respond to the regulatory findings. So I learned a lot about the regulatory world at that time. Ultimately went on to actually be the person who oversaw the regulatory department here. And I will say that if we carry this forward, skilled nursing is an incredibly regulated environment, and I am so grateful for sort of having this history that exposed me to the regulatory world early on. Also spent a lot of time in the quality, safety, sort of risk management worlds. Again, this is sort of connected to errors and other things. And interestingly, while the risk management issues that I'm dealing with now aren't quite as patient focused as they were here, sort of being able to speak a little bit of the language and understand it a bit is very helpful in this kind of a role. The other thing that happened during this time frame was there were a lot of nursing strikes and other labor strikes. And one of the things that we had to do was prepare to make sure that we could continue to care for all of our patients and function clinically while the strikes were going on. And I will say that while my role there was really to help prepare clinically, I'm sort of grateful that I sort of paid attention to all of the HR and labor and union related types of discussions, because fast forward, I spend a lot of time with my chief human resources officer now, and these are the things that we talk about. And so one of my messages that I'm going to share in a little bit is, if you're in a physician leadership role, if you're a medical director or a service chief or, whatever the role is, paying attention to the things that aren't sort of squarely in the physician domain can be very, very helpful. And I've seen a lot of medical directors here just focus like very narrowly on the physician related things and not want to sort of get involved in anything that was, related to another discipline, for example. And I would say that paying attention to those other things, if you're a clinic medical director, knowing what your clinic manager is doing in terms of their budget, as an example, can give you some insights into the finances of how the system works. And so sort of paying attention to those kinds of things, I think pays off down the road. And it's really interesting. I will say that the other important thing that I did in terms of leadership training was when UCSF brought in a variety of different leaders over time to both teach lean leadership skills and to help to deploy lean management systems here, learning the sort of lean way of thinking and operating and behaving. It was very, very helpful. I think we were talking about this earlier as well. One of the teachings is not to jump to solutions. So if you've got a problem, make sure you really know what the problem is before you start solving the wrong problem or implementing things that are addressing the wrong problem. And I would highly recommend for folks sort of thinking about leadership, probably in any domain, to understand lean a little bit. And then in the far column, under the San Francisco Campus for Jewish Living, I put something in normal font and some things italicized. All those things that are italicized are things that are like outside of my comfort zone. But I feel like I've done just enough and know the right questions to ask to be able to sort of access the help I need to do all of these things in my new role. And it's really fun to learn every day. So I tried to synthesize all of that into some important skill sets. And I think I've mentioned most of these already Finance, I think both just understanding some of the terminology, like everyone should probably know what EBITDA is. Understanding it takes some time, but just sort of understanding some of the lingo is helpful, and being able to write a business plan or have someone help you write a business plan so that if you're proposing something new, that is going to require an investment, that you've thought a little bit about the return on investment. And Stephanie and I have talked about this quite a lot. The ROI isn't always dollar signs. It can be in, quality or avoidance of safety issues. But knowing what your ROI is can be very, very helpful when you're going to someone to make a plea for funding. Project management, change management, knowing how to run a meeting, not necessarily intuitive. And some people do it really, really well. And we've all been in meetings where we want to give someone some, the leader some advice. Communication skills are very important. Being able to coach and mentor so that you're not just sort of, telling folks what to do, but helping them to learn how to solve problems on their own. And then, I think, one of the places that I feel like is weakest for me is in strategic thinking. And this is a really important skill for, I would say, executives in the C-suite. We just started a 3-year strategic planning process. And so I'm really forcing myself to get out of my box and get into the strategic thinking. And then in terms of just some leadership lessons, I think it's really important early on I would say, to say yes to almost everything. If there is something that just, doesn't resonate with you at all, I think it's really important to be able to identify that. And, don't say yes just because Louise, really wants you to do it. But on the other hand, like if Talmadge is asking you to do something, you should say yes. Right? There's just, you have to balance some of those kinds of things. But I think early on, really considering at least saying yes to things or having a really good reason why you're going to say no is really important. I already talked about paying attention to the non-physician focused work. I think staying true to your core and being authentic is really important. I think for me, that has always been that doing the right thing for the patient comes first, even if it's going to be expensive or cost us money or whatnot. And then also, I think it's really important to know that there are different leadership styles, and some people will ask, like, what is your leadership style, as if you only need to you can only have one. And I think that people can use different leadership styles at different times. And I think the best example that I could come up with is really in times of crisis, it's okay to just make a decision. And frequently people are really looking to leaders to make a decision. And, I think we all know things can be kind of democratic here. And that can take a lot of time. And there's some situations where it really is okay to make a decision. And COVID times was a really good example of this. But then most of the time, what you want to do is not to micromanage and to help people build problem-solving skills so that you're all working together to achieve the organization's vision. Stakeholder engagement is really important. I think the things that have been like the most epic failures for me have been the things that I didn't take the time to get appropriate stakeholder engagement in advance of trying to roll something out. And then lastly, and this sort of relates to those italicized areas on my last slide, I think that leadership skills they really are transferable, I have learned. And so while I don't feel like I know anything about marketing, I realize that if you're a good internist, you can diagnose the problem and then you can get help to solve the problem. So I'm going to sort of finish my journey there and move on, tell you just a little bit about what we do over at the San Francisco campus for Jewish Living. And then we'll talk about some of the things going on in the post-acute market. So this is our 9-acre campus over at 302 Silver Avenue. I know it is not on everyone's beaten path, but I know most of you have been there, for which I'm very appreciative. I learned recently that this sort of 9-acre plot of land was purchased by a Jewish sea captain, like in the 1800s, and donated to the community. It was actually first an orphanage, and then quickly evolved to become what was then called the Hebrew Home for the Aged. And as I walk around, like, we have such a privilege of space. I'm very thankful for the vision of the folks who who purchased this land. So these are all the different services that we provide at SFCJL. We're working really, really, really hard not to call it the Jewish Home, but to call it SFCJL, or the campus. So the Jewish Home and Rehab Center is what we've commonly referred to as the home, and that is a 375-bed skilled nursing facility that's licensed by CDPH. It includes a long-term skilled nursing facility that's about 200, a little over 240 beds. Those are in the Goodman and Corrett buildings. Goodman is the building that was built in the 60s, the oldest building on the campus. 98% of the residents who are there are supported by Medi-Cal. In California, all of Medi-Cal has been pushed into managed Medi-Cal in the last year. And then we have a few patients that are VA patients, a few Kaiser patients, and some private pay patients. This includes one of the floors in the Goodman building is a locked dementia unit, and then we have 2 floors in the Goodman building that are largely Russian-speaking immigrants. We also have the short-term skilled nursing facility, or the post-acute rehab, which is the area that you're most familiar with. Michi is our medical director there. So the building actually has 120 beds. Our short-term census, though, is around 90, but the building is full with other long-term care patients. People always ask sort of who funds patients in each of these buildings, which is why I've included in here the Medicare other mix. So it's about 50% Medicare A and about 50% commercial, and that is sort of a combination of Medicare Advantage or managed Medi-Cal, or folks who have commercial insurance and are younger than 65. And then one of the unique things that we have is a 12-bed inpatient geropsychiatry unit. This is a 12-bed unit, and there are very few, as you all know, geropsych units. I think there may be, I've heard 3 in California. There probably aren't very many in the entire United States. And it's just, I think, amazing to have this ability to not have the 18-year-old and the 80-year-old right next to each other with their unique mental health needs. So it's really a gift to be able to have. And then the newer part of our campus is the Frank Residences. And this is a 190-unit assisted living and memory care. This is licensed as an RCFE by California Department of Social Services. The assisted living is 113 apartments. There are studios, 1 bedrooms, 2 bedrooms, and the memory care is 77 apartments. And memory care is sort of a nice sized bedroom and a bathroom, and they're organized in sort of locked neighborhoods with an activity room and a dining room. So it's pretty all inclusive, although many of the residents do come out with with a caregiver to take advantage of our life enrichment programs. Our assisted living is and the memory care are both private pay, and the way it works is that there's basically a baseline rent. This is month-to-month rent that is your room and board, and then the care services are added on in terms of fees on top of that. And then we have this thing called Buyer Square, which is sort of an unrealized element of the campus at this point. When Frank was conceived, Buyer Square was meant to be like a mini JCC or a community center, where in addition to our residents using the pool and the art studio and attending lectures, it would be open to the public to buy a membership and be able to come in. And that has not been realized due to COVID. So Frank opened in September of 2020, not an ideal time to open an assisted living. And we still have not filled up to the level that we would like to be at. And we're starting a strategic planning effort where I'm calling, one of the pillars Buyer Square 2.0, like let's re-envision what this thing looks like and get that geriatric primary care clinic opened as part of it and some other things. And then one of the things I wanted to mention is that our life enrichment programs really sort of weave across all of the different elements of the campus. And I would say that that was one of the things that I was most surprised by, was how robust our life enrichment programs are and how important the factor of community is. So I put together a couple of photos here so you could get a flavor for the programs. So we had these dragon dancers for Lunar New Year. They have these like Italian dining nights where they go up to the long-term care units and set up the checkered tablecloths. We have all sorts of gardening types of programming. I got to participate in the Latka cook-off. And then the bottom over there on the your right is one of the Passover Seders yesterday. So there's a really nice balance between the sort of Jewish programming as well as programming that everyone can take advantage of. And I think what I was most surprised by is that, if you walk around on any given day, our residents are in real clothes, they're out of their rooms, and they are engaged in activities to the best of their abilities. So our life enrichment coordinators really meet them where they are at, which I think is really nice to be able to see. And then lastly, I just wanted to share, SFCGL is pretty big. So our skilled nursing facility actually has the largest number of admissions in San Francisco. Laguna Honda, as you all know, is much larger, but they don't turn over as many patients. So we take care of about 2,500 people over the course of a year, and about 600 people on campus on any given day. And just in terms of just other staff, so you sort of know what I walked into, we have about 800 employees and 300 volunteers to make everything happen. So that's a little bit about who we are, and I'm happy to answer other questions later. But what I thought I would sort of wrap up with is really to talk about what some of the trends are in post-acute care right now, or sort of also titled, What Keeps Me Up at Night? So the aging population, staffing shortages, cost of healthcare, the rapid growth of people moving from Medicare A into Medicare Advantage, the increasing preference for people to receive care at home. And I think you could probably couple that with, given the increase in the size of the population, there's no way that we're going to have enough facilities to care for folks. So by necessity, we are going to need to figure out how to take better care of people in their homes. Long-term care reimbursement and the landscape of long-term care. I won't talk about this too much more, but long-term care is, essentially funded by Medi-Cal, and Medi-Cal has sort of pushed everyone into managed Medi-Cal programs, and it's very unclear how well or how we are going to be reimbursed at what level as the managed care programs take over for long-term care. We also anticipate that they'll probably be engaging in more preferred provider networks. And so there's a bit of an unknown out there related to long-term care right now. And then I think there's just a lot that I imagine many of you have read as well, of people just reimagining long-term care. Like, are the many folks who are receiving long-term care right now, are their grandchildren really going to need to be in a skilled nursing facility? And I think about it with our 2 floors of Russian immigrants. Like, are their grandchildren really going to be needing long-term care? Will they be receiving care in their homes? I know that we will need skilled level care for some segment of long-term care, but I'm not sure it needs to be as big as it is now. But I don't know, maybe with the growth of the population, we'll still need more beds. It feels like a big unknown that we all need to think about together. And then I alluded to this earlier, the regulatory environment has been stringent, and it is increasingly stringent over time. So I thought I'd talk a little bit about the first 4 of these in a little bit more depth. So I know that you have all seen this related to the aging population, but it's hard not to include, the number of folks over the age of 65 that we anticipate in 2040 and 2060 is huge. And the number of people who are going to be over 85 also rising rapidly. And so the ability to provide the senior care that is needed in our clinics, in the home, in facilities, I think unless we start addressing it now, we are going to be in trouble. And then I think that we are going to have the need to adapt sort of outside of the hospital setting to need to be able to take care of folks at a much more complex level, both in the home and in our facilities. And that's one of the things that we're thinking about. In terms of the greater complexity, I thought I would just share some of the things that we are thinking about. So, we need to grow our complex care services to better accommodate the, patients who are, coming from here who will, have had a transplant or, you name the complex scenario. We need to be able to adapt to that and take care of it. And I think one of the things we're thinking about is pathways or creating centers of excellence for certain diagnoses, and really trying to bridge the continuum in a much better way. So I think maybe we've, done a little bit at the, the hospital to skilled nursing facility transition. I think the skilled nursing facility to home is something where, we don't have any relationships with home healthcare agencies as an example. I know that there is some communication with primary care physicians, but maybe not enough. Could our subspecialists actually do teleconsults to see some of the folks they discharge in the skilled nursing facility? Because otherwise it's hard to get people to appointments. So I'm wondering how we can create some pathways to bridge all of that to smooth things a little bit. And then, as I mentioned, partnering with home care agencies and really thinking about augmenting our clinical services in assisted living and memory care. The folks who are moving into assisted living and memory care are far more frail and older than anyone imagined, at least when our facility was built. And so we need to be able to adapt to that so that we can continue to care for the folks who are undoubtedly going to continue to move in. So the other important thing going on related to senior care right now are staffing shortages. So unfortunately, while many things in healthcare are showing signs of rebounding, the nursing and residential care facilities are still really low and have not gotten back up to the pre-pandemic baseline. That has been really, really hard on us. And in addition to just not being able to bounce back, we have continued churn and turnover, which is just incredibly costly and impacts quality. So our staff turnover rate, this is 2022 data, it's about the same now, is 26%. So we have 800 employees. That means that, right, a quarter of those folks turning over during the course of a year, that all the new people coming in need to be trained and oriented, and right, it's huge. But we're not alone. This is what the rest of the landscape looks like in terms of all the other skilled nursing facilities that you know in San Francisco. The most critical or the most abundant provider in the skilled nursing setting is the CNA, and that is the bulk of what this is, but not all. We've had workforce issues in all disciplines, from the folks who work in the kitchen to the CNAs, nurses, et cetera. And in the state of California, there's a lot of funding going towards trying to train more CNAs and home health aides. And I'm hoping that there's a lot of innovative programming that's going on, a lot of funding for people to go into CNA training programs, and then to sort of support them once they're in their jobs. And I've got my fingers crossed that some of that helps, but I think that, for us, we are thinking a lot about how we onboard people, how we hire the right person, how we onboard people, and then how we retain them. That's actually taken up quite a bit of my my thinking since starting and really trying to partner with a bunch of sort of different innovative organizations to see what we can do to improve on this. And I thought I would quickly mention physician staffing. I think our model is that we have our 30 patient UCSF service in the post-acute side, with many of you caring for those patients. But all of our other skilled nursing residents and patients are cared for by community physicians, and not very many of them. There are very, very few people. We lost someone this last year. And I don't think that this model is going to be sustainable for the future. And so, thinking about, what we can do with partnerships and, hospitalist companies that also have SNFs and the like, I think is going to be really, really important, because the age of the folks who are coming in from the community to do this, they're all going to be retiring soon. And I don't see that there are sort of new young folks in private practice who are going to be taking over for them. Shortly after I started, I did an informal survey with all of the CEOs through American Jewish Aging Services. So it's basically all of the, San Francisco Campus for Jewish Living sister organizations across the country. And I got about, somewhere between 12 and 15 responses. And the things were all over the map in terms of how people did their staffing model. Some were doing just what we do with private practice. Some have relationships with academic medical centers, as we have. Many were contracted with SNFist type companies, and a few employed their physicians, which we cannot do in California. So, one of the things I've been thinking about a lot is that if we don't expose our trainees to this space, we are not going to have a workforce to meet the demand. And so would love to partner with all of you to think about how we can increase that exposure. I think not everybody needs to come and work in a skilled nursing facility. So even if they just understand the environment, we are way ahead of the game from my perspective. And then lastly, just a little bit about the soaring costs of healthcare. So this and related to skilled nursing facilities. So skilled nursing profitability way down in 2022. It was already down in 2019. There were a ton of relief funds that got pumped into skilled nursing facilities in 2020 and 2021. That's why they look a little bit better there. But skilled nursing facilities are still very much recovering from the shrink in occupancy during COVID. The workforce shortages forced everybody to use registry nursing and these contracted agencies, which are crazy expensive. And so it was really, really hard to keep up from a financial perspective. So I think this is sort of what we're up against and trying to move the needle on. I wanted to just share a little bit about SNF reimbursement. It's really complicated. I don't fully understand it yet, but I'm working on it. I mentioned that long-term care is primarily Medi-Cal and sort of has moved into managed care. The way that they determine our rates is by this 3-year look back, where we basically, submit our cost reports with every last cost that goes into caring for a resident in the skilled nursing facility, and then they come back with a rate that is adjusted based on our cost report. We actually, because we have our acute psychiatry unit, we are considered hospital-based, and that is nice for us because it gives us a little bit of a boost compared to an independent skilled nursing facility. And then on the short-term side, Medicare A pays for the first 100 days, and the way that the reimbursement is calculated now is through this new PDPM calculation, where they sort of look at different patient characteristics to. Value-based purchasing contributes to a small amount of the reimbursement, and that is the metric that is largely looked at here is readmissions while at the skilled nursing facility. And then all the commercial plans, whether it's through Medicare Advantage or the managed Medi-Cal, managed other, younger patients with a commercial plan, those are all negotiated rates between the skilled nursing facility and the the insurance company. And those, can be highly variable. And can also be impacted by quality. So one of the things we, work on all the time is making sure that our quality is as good as it can be, because it can impact not just the patient outcomes, but our reimbursement. And then just to give a little bit of a sense of the, just kind of the proportion of reimbursement, I took all of the numbers off of this, but you can see that sort of the long-term, Medi-Cal reimbursement for a day is much, much less than, say, the short-term rehab Medicare A, which is less than what an acute psychiatric day is paid for. The other thing that I think is important to note is that the short-term rehab, while it's 24% of the average daily census, it's actually 30% of the reimbursement. And so that is where, for us, that's kind of our lifeline, is that short-term post-acute population. And then I know you're all dealing with managed Medicare Advantage, either in your clinics, perhaps, but they have lots of strategies to sort of try and contain costs. And at the same time, the number of people that are moving into MA is like increasing by the day. We're over 50% in California now, so we've sort of lagged behind the rest of the country and are now catching up. And you sort of know all of this, but they're reimbursing at lower rates, are really trying to control length of stay, both in the hospital and in the skilled nursing environment. They're linking their reimbursement to quality outcomes. So all things that create pressures on us as providers. And a lot of skilled nursing facilities are responding by sort of creating preferred provider networks and sort of getting in on things. But also looking for alternate revenue streams. So there are these things called special needs plans, or the SNPs, as they say. So if you are a large enough, like a for-profit skilled nursing company with many skilled nursing facilities in one area, you can get in on this and actually share some risk with the plan. And that can be a revenue generating stream. We're not big enough to do it, and we're one of the biggest SNFs, independent SNFs in the area. So looking ahead, just in terms of the things that we're focusing on, just to give you a sense of the many different areas in which we might partner, we're thinking about right-sizing our short-term and long-term care, really digging into what we can do in terms of clinical services to support complex needs, thinking a lot about how we partner or build programs to develop the workforce for the future. And then, I think with our size and scale, we're really an ideal place to be a hub for education, training, and research. And then I think as we sort of think even bigger in terms of planning for future generations, it's really like, how do we reimagine, the care so that we can achieve the scale we need to care for, this rising number of older adults, and it's going to require workforce. And I think a reimagined way of caring for folks, because we can't care for everyone in a facility or probably in the home. Like, what do we do in communities? I think there's just a lot of different things we need to think about. I'm sort of stuck on the 3-year side right now. So just really quickly, there are an increasing number of physicians who are, working in administrative and executive roles, either medical directors, chief medical officers, or CEO type of roles, or chief health information officer kinds of roles. And my advice would be to just take advantage of opportunities to gain experience and training and mentoring along the way. I think you can do that and see if, try it on for size and see if it fits. And then really lots of opportunities to reimagine and innovate in this space, which I know you are all already doing. So thank you. Happy to answer any questions.
about is as a teacher affects eternity. So we appreciate all that you've taught us.
Oh, that's very sweet. Thank you.
There you go. I'll open it up for questions. Any questions? Might lead off because I'm struggling here. I mean, the workforce thing is a huge thing. In addition to thinking about how to train people in the setting so they see it, there's some other thoughts about how to get people interested in this setting. I always feel like the nursing home is such a oftentimes forgotten setting, but it's a place you can innovate. It's a place you could do things. But anyway, I'm just curious on how to make that on people's radars.
I think it's getting people into the space and as early as we can. So, we have some programs with some high schools where, they can come in and actually do an internship their senior year. So I think it's things like that. And, for some of them, they'll never think about a nursing home again. And for some, it's going to stick. And when they decide that, medicine is their passion or nursing is their passion, maybe, they'll want to be in this space. And I think the same thing, holds for, for physicians. If we can get, medical students in, right, I think more and more people will understand the space. And hopefully it will stick for some of them. But I think we have to move the needle way earlier. One of the Jewish homes in New York, the new Jewish home, they have a huge high school-based training program where they bring people in very early in their high school career, either they're like freshman or sophomore year, and they have this program that goes all the way through. They actually train them to be CNAs while they're in high school. And then, some of them go on to be nurses, some have gone on to be doctors, like that they're getting them really, really early. And I think that's we have to catch them early.
Let's see, I think we do have a question online here. Great talk. It says, what are your thoughts about the preparation physicians receive in residency training for taking care of patients in skilled nursing facilities, both post-acute and long-term care, sort of the experience people have in residency?
Well, my experience is limited to what I saw here. So I don't know what it's like elsewhere. I think it's very poor. Right? There are not immersive experiences for folks. I mean, not even a 2-week experience. And I think if you, happen to have a clinic attending or, hospital medicine attending who has spent some time or likes thinking about transitions and knows a little bit about a skilled nursing facility, maybe they'll share that with you. And so that you'll think about it down the line. But I don't think we're getting people exposed enough to, what it's really like to be in the skilled nursing setting. But
on the CNA kind of hands-on workforce, are there different models in, say, different countries of how that workforce is developed and sustained, and models other than at some places in the U.S. that model is very precarious, low income, assuming it's low skill and replaceable, and it's actually a very highly skilled job, and one imagines could become the sort of job that can sustain a career and the factory work of the 21st century. Are there different models around the world for that workforce?
I think that's a great question, and I don't know yet. But I will say that it seems as if there's a cohort of people that get their CNA certificates and stay CNAs, and then there's definitely the cohort that gets their CNA certificate so that they can become an LVN, so that they can become an RN. And I think we need to foster both, because we need some folks to make a career of being CNAs, but then it also is really nice to have that other pipeline. I've also discovered that there aren't career ladders per se for CNAs. And you sort of think about career ladders in other areas. It's like you become a CNA and you stay a CNA, and you may not have the ability to become the unit expert in pressure ulcer care or falls prevention or, whatever the skill is. And I think if we can maybe provide some training around some of these other clinical needs, maybe we can help to create some of these career ladders for them.
You'd mentioned a little bit about reimagining or sort of thinking about, what is it, BioSquare 2.0. I'd love to hear sort of what I know you're starting the strategic planning, but sort of a little bit about what you're thinking of for the future of SFCJL. Because I always like the idea of BioSquare where you're bringing people from the community in. And I think that's another way of having more visibility for our skilled nursing facilities.
Yeah, completely agree. I mean, I would like very much to build on things that are related to clinical care because I feel like that's our superpower, right? We've been doing this for many, many years, and that's what I've been calling our superpower. So I'd like to keep things sort of as healthcare adjacent as possible. So I think about the types of things we can do from a healthcare perspective, and then the sort of healthcare adjacent kinds of things. So I think, clinics, PACE program, those kinds of things on the healthcare side, but then thinking about care management or helping people to sort of figure out, their durable power of finance and like sort of, some of those kinds of estate planning kinds of things that people might need help with. So some of the things that people really struggle with at the end of life. And again, we could bring people onto the campus through that. And then I think about just educational programs, and I think that those could be both, sort of healthcare adjacent and any kind of cultural program that, we might want to envision. And then I think there's a health and wellness piece. We already have a fitness center, and we've got personal trainers that are working with our residents. And a lot of, just it's so much fun to watch these chair fitness classes, right? People could come in and do those kinds of things. And you could imagine a variety of those different kinds of classes there. And then, things in sort of the, cognitive dementia care around memory care types of services as well.
So you're taking me down this trip down memory lane because I love the Jewish home and I spent 4 years of my life hanging out there. Once upon a time, about 20 years ago, they had an adult day program. And I know there were plans to sort of rejuvenate that after the massive renovation of what was then the Jewish home. Is there a thought of incorporating an ADHC into this BioSquare?
I think
Or
that's,
are there reasons you were on the board at the time, more than I do about why the second ADHC just sort of didn't emerge.
Yeah, that was prior to my time, so don't actually know much about it. I think it's all sort of up for grabs in terms of how we use this space. The other thing that we have is we have retail space that's unleased on Mission Street under one of the apartment buildings. So again, like we could use that for adult day health or a PACE program or something. We could also, let someone lease it and have a grocery store. Like trying to figure out what the community needs is, I think, what we need to spend the next, 6+ months doing. Thank you.